Hello, my name is Francine and I'm the CEO of the Lullaby Trust. Today I'm going to be talking about how the charity is continuing to drive down sudden infant death syndrome, or SIDS as we call it, and we do that very much with the help of health visitors. I also want to talk about our continued determination to solve the mystery of sudden infant death through research. First of all, let me tell you a little bit about the Lullaby Trust. Most of you know us, I'm sure, but the Trust was founded in 1971 and we were originally called the Foundation for the Study of Infant Deaths, or FSID, as we obviously got abbreviated to. In 2013, we changed our name to the Lullaby Trust, and we continue to do the same things that we had done since 1971. Essentially, that's to provide specialist support for bereaved families who have lost a baby to SIDS or through sudden infant death. We promote expert advice on safer baby sleep, and we try to keep awareness high about the risk of sudden infant death. We also work very closely with the NHS, and many of you will be familiar with our National Health Visitor-led service for bereaved parents, Care of the Next Infant programme, or CONI as we call it. And this is a service which supports families before and after the birth of their new baby. The third area that the Lullaby Trust is very strongly associated with since its inception, of course, is to support research. And we do that to understand why so many babies, 600 babies a year, die suddenly and unexpectedly in the UK. And we need to continually strive to find out why these tragic deaths occur. So let's talk about what sudden infant death syndrome is. And here's a definition that you'll be very familiar with. Sudden infant death syndrome is the sudden and unexplained death of a baby or toddler where no cause is found after detailed post-mortem examinations. The coroner registers the death, and this can vary. It can be registered as sudden infant death syndrome, sudden infant death, sudden unexpected death in infancy, unascertained, or cot death. Nowadays, most coroners are likely to register a death either as SIDS if the post-mortem has clearly indicated that a SIDS-like pattern has occurred, or if that isn't indicated, they are likely to register the death as unascertained. In 2015, ONS told us that across the UK, 290 babies and toddlers still died of SIDS, which is still a very significant number. It equates to approximately 5 babies every week. So let's look at health visitors and how important you all are to the work of the Lullaby Trust. The latest SIDS rates, which came out actually only very recently last month in August, are the lowest on record, and we are very, very pleased about that. We feel this could not have been achieved without the commitment of health visitors. In 2015, our regional staff trained over 5,500 health professionals, most of whom, not all, but most of whom were health visitors, and we gave training on safer sleep advice and the evidence behind that. As I've already said, we offer the Care of the Next Infant program to bereaved families, and this is only possible through health visitors giving up their time to train as CONI coordinators to allow us to have the service comprehensively commissioned throughout the country. So when we say that the Lullaby Trust and health visitors work together in unique partnership, we mean that very genuinely, and we strongly feel that the drop in SIDS has only been achieved because our charity and health visitors have worked so closely together over many years. So let's see now what we have achieved together. And this is a graph that some of you may have seen, but it never ceases to make me very glad indeed, because what you can see there is a huge drop, an absolute dramatic drop in the numbers of the babies who have died since the late 1980s. And this is largely due to the Back to Sleep campaign that was promoted across the UK in 1991. And this then led to a cliff edge drop in the number of babies who died, and then what we see as a slower and steady decline of the numbers of babies who have died as a result of SIDS. This graph takes us right up to date. It shows there was a blip in 2013, but in 2014 we see that the numbers of deaths have gone down, and as I said previously, this number, 212 sudden infant death syndrome deaths, the lowest ever on record in England and Wales. We haven't got the figures yet from Scotland and Northern Ireland, but when we do so, we will be promoting those numbers on our website. We're hoping that we may be now talking about 250 deaths per year as opposed to 300 deaths per year, which is very significant over a 5-year period. So watch this space, and we'll see whether we've dropped that number. Let's go to why this number has come down. The drop in SIDS is entirely due to the advice we all give to parents. This is based on 25 years of international research in terms of identifying how we can reduce the risk of SIDS, and the research has enabled us to produce evidence-based advice. And in a moment I'll go to the slide on our core advice, but if you're interested in understanding the basis on which our advice is given, then have a look at our website and go to our evidence-based page, which will give you a very up-to-date summary of the research that underpins our advice. And this is the advice we offer, and all of you will be offering to the families you work with and you'll be familiar with, but absolutely worth reiterating. The things you can do to keep your baby safe and reduce the risk of SIDS: always place a baby on their back to sleep. Keep the baby smoke-free during pregnancy and after birth. Breastfeed your baby if you can. Place your baby to sleep in a separate cot or Moses basket in the same room as you for the first 6 months. And, of course, to use a firm, flat, waterproof mattress in good condition. The don'ts are very, very important. Never sleep on a sofa or an armchair with your baby. We also strongly advise don't sleep in the same bed as your baby if you smoke, if you drink, you take drugs or are tired, especially important if your baby was born prematurely or is of a low birth weight. Don't get your baby too hot, and of course don't cover your baby's face or head while sleeping or using loose bedding. Now that advice essentially hasn't changed for 25 years, and that is the advice that has saved so many babies' lives. We have estimated 20,000 babies' lives over the last 20 or so years. However, we still have more to do to crack SIDS. So although we know how to reduce the risk of SIDS, and we have had tremendous success, we still don't know what the mechanisms are that cause a baby to stop breathing. And why is it that some babies die and most do not? For example, we know that the rates of smoking in pregnancy have gone down, but it's still something in the region of 70,000 women who still smoke in pregnancy. And we know that that can cause serious harm to the baby. But of course, not all those babies die of SIDS. And why do babies die when parents follow all the advice. They do everything right. They sleep their baby correctly. They don't smoke. They breastfeed. And yet a baby, apparently healthy baby, will die. And we still need to understand how to resolve those questions. So the Lullaby Trust, which has funded nearly £12 million worth of research in 45 years, which is a huge amount for a small charity, decided that we needed to move forward on our research agenda. We needed to really see if we could crack SIDS in the next 20, 30 years. But obviously, in order to do that, we need to invest in research. So with the support of a charity called Teddy's Wish, which was set up by two bereaved parents, Jen and Chris Reed, a couple of years ago, we were able to fund a project called GAPS, which stands for Global Action and Prioritisation of Sudden Infant Death. And the project was specifically designed to work internationally with other charities, other SIDS charities across the world, to identify the current gaps in current research and to find a consensus amongst the SIDS community, if you like, on what our key priorities should be in the next 10 years in terms of research to help us reduce SIDS and hopefully completely eradicate it in the next 20, 30 years or so. So how did we actually go about this project? The first stage was to initially identify what the key themes might be. So together with our colleagues in America, the American SIDS Institute, and in Australia, SIDS and Kids, we sent out a survey that reached out to a range of different disciplines, academics, and of course bereaved family members. And that's quite important. This is the first time we've asked parents to determine the research priorities for us internationally. And the first survey that was designed was sent out to over 80 individuals, and this was sent out to those individuals in 20 different countries. And you can see that the USA responded very vigorously. And this is the list of respondent countries who replied to the first survey. And you can see that 12.5% of the survey respondents were from the UK. From that survey, we got 516 suggestions, which we gradually reduced to 41 individual research priorities. If we go to look at the different types of individuals who contributed to the survey, you can see a lot of academics represented in that group, along with a range of different clinicians. Now, within this, there will certainly be a number of health visitors, both in this country, but also in the States and in Australia and the other countries represented. So we were able to identify 41 individual research priorities, and we then decided to put out another survey. We got the 41 research priorities identified, and we wanted to really understand of those 41 research priorities, which were the most important to this group. And we were able to extend this survey more widely, and in this case we can see that bereaved family members and healthcare professionals were equally represented, which is very very encouraging, and we got 612 completed responses, and we had 18 different countries represented. And from this exercise, we were able to establish 30 research priorities, which we then took to a ranking workshop. If we go to the next slide, we'll see these were the countries that responded. And interestingly, UK comes out top here. Nearly 50% of the respondents were from families and from the wider SIDS community in academia and amongst healthcare professionals. And if we go further on, we can see how the experience and expertise of the respondents to the second survey breaks down. And you'll see that 64 health visitors, 10% of the survey respondents responded to the survey, and we're exceptionally grateful to those of you who did respond for that. So then we come to the workshops themselves, and you'll see that these workshops only took place towards the end of the year. And we had 3 workshops, and it was all very exciting. We went to the USA and to Australia, as well as holding a workshop in London. And the idea was that each workshop had the 30 priorities that had been identified through the survey process, and we were very strict with everybody. We said they had to make those 30 priorities into top 10, which is not easy. 56 people took part, 23 in the UK, 17 in the US, and 17 in Australia. And we made sure that within the workshop settings, we included doctors, researchers, bereaved family members, public health professionals, and of course representatives from the charities. At which point we asked each workshop to agree a list of final top 10 priorities. We allowed them to make 1 or 2 wording changes, but generally they had to stick to the priorities that had been given them from the original 30. So again, this breaks down the numbers of people who attended the UK workshop, and you can see that we had paediatricians there, we had a significant number of bereaved family members there, we had researchers there, and you'll be delighted to see that we had a very good smattering of health visitors at the UK workshop, and they were able to make a fantastic contribution. So, what were the top 10 research priorities? Well, I'll go through these very, very, very briefly, but you can see the top 5. The first one was to develop new ways to make safe sleep campaigns more effective. Clearly, we need to continue to inform parents how to keep their babies safe from SIDS. That's an ongoing process. But some of you will know that the vast majority of SIDS now takes place in more disadvantaged communities, and therefore we need to address that by thinking about how we can make our safe sleep messaging more directly relevant to particular groups. The second priority, again, plays to the fact that we just don't know why babies don't wake up, and there is still a need to understand what the mechanisms are that cause a baby to collapse and die, and what are the other factors, for example, environmental risk factors that exist and interact with the physiology of the baby. So that is still a major priority for us. We thought that we needed to improve the way we collect data on SUDI, i.e. sudden unexpected death in infancy, and non-SUDI deaths, because that will allow us to compare and contrast what is happening in both groups. Pathologists are very keen on identifying what the specific biomarkers are in determining the cause of death, and we've done some very exciting work with Professor Neil Sabir at Great Ormond Street to look at what the key proteins are when a baby dies, and whether that is a clue to helping us to understand why the death occurred. So pathology still is a major source of research for us. And then the fifth area, in terms of the top 10, is to understand the different social and cultural factors that affect parental choices in sleep practices and responses to risk reduction campaigns. And I'm sure many of you will be aware that different groups, socially, culturally, respond to safer sleep information advice in different ways. And I think it would be very important for us to look at that. So, for example, young parents are a high-risk group, and we need to understand why it is that young parents, particularly those under the age of 20, are less likely to respond to safer sleep messaging than other groups. So let's look at the bottom five. The sixth priority is to really understand how parental smoking, including vaping and nicotine replacement therapies, play a part in SUDI, sudden unexpected death in infancy. Genetics comes seventh. Some people thought genetics would come higher, and in fact it did come higher in the other countries. But clearly we feel that it is an important area, but it's not the number one issue. We need to also identify what factors are associated with SUDI where all aspects of recommended risk reduction have been followed, and that particularly relates to those parents. Probably about 25% of the cohort of parents who lose a baby do everything right. So why is it that their baby dies? And then penultimately, we need to better understand the risk of sharing any sleep surface with an infant, notably how it interacts with other factors. And clearly, this is quite a controversial issue in relation to co-sleeping, and I know many of you will be involved in this debate. But the fact is, why is it that a baby is more prone to die of SIDS in certainly unsafe co-sleeping situations, and even where there are no risk present, there's still a risk of co-sleeping and SIDS, albeit a small one. So it is an area that needs to be explored. It'd certainly help us if we had more evidence to explain why co-sleeping in certain circumstances was risky. And lastly, which is something that may be of interest to all of you, we need to refine how we get messages through to health professionals so they can proactively help to reduce the risks of sudden unexpected death in infancy. And we'd be keen to get some ideas from all of you about the sort of research we should be carrying out in relation to that. In the other key piece of work that we did as part of this process was to look at what the broader priorities were over and beyond research priorities. And so what we did in the workshop was we gave everybody a series of different statements, if you like, that they could sign up to. And these were the top 5 statements that the group felt needed to be borne in mind in relation to the research agenda. Firstly, we need to move from the single factor prevention approach to addressing the variety of risks that impact on a family. So it's clear generally, and it's agreed across the world, that SIDS is likely to be caused by a range of different factors. So we actually need to proclaim that more, and we need to accept that that SIDS occurs for many reasons, and they interact together. I think it's fair to say that SIDS now is a health inequality issue. It probably wasn't 30 years ago when you saw that SIDS affected many families across the wider social spectrum, but now primarily, as I said earlier, it occurs in more disadvantaged families, and we need to look at the impact of disadvantage and SIDS, and that might well help us to resolve how we reduce it further. All SUDI should be studied, not just SIDS. So in other words, we need to be looking at unexpected death in infancy as well as sudden infant death syndrome. Sudden infant death in infancy can be divided into SUDI, and SIDS is a subset of SUDI. As I said earlier, there's something like 600 babies that die suddenly and unexpectedly. Of those, we have 300 that are explained and 300 that are unexplained. The postmortem will reveal an explanation or not. And this priority or statement is just reiterating that, as well as looking at sudden unexplained infant deaths, we should look at all sudden unexpected deaths. We need up-to-date data, and I think everybody would agree with that, in order to carry out large-scale studies, and this probably needs to be agreed on an international level. Fourthly, we believe, and again, this will be something that will be interesting to get your feedback on, that awareness and prevention of SUDI, SIDS should be mandatory in the training of all healthcare and early years professionals. It isn't currently, but we believe that it would be important to ensure that this is now a mandatory part of training for anybody who is working with a family with young children. And last but not least, there should be a standardised and common approach to postmortems in all cases. Sadly, that is not the case internationally. There are different standards, and in this country, the approach to postmortems can vary. Although, from my experience of being at the workshop in Australia, I can tell you that we are a lot further advanced than our colleagues on that side of the world. So those were our top 5 priorities. As I said, we had 3 workshops, one in Melbourne and one in Miami. And there was consensus between the countries. So it was clear that studying the mechanisms leading to death and how they interact with environmental risk factors at different ages and gestational stages was very important in the US. It came second in the UK and fourth in Australia. And what that tells us is the old chestnut. I mean, why does SIDS happen? What is going on physically with the baby? We still don't know. And so that has to be a key research priority. The other area of consensus was, enabling best practice processes and systematic data collection and sharing for accurate classification of deaths to inform research and prevention. This is quite a big problem. People have different processes, different ways of collecting data, and this then becomes quite an issue in terms of research and making any type of comparison. This was ranked first in Australia and third in both UK and the US. So we've got to get better at collecting data and ensuring that we all collect the same data in the same way. So those were the key areas of consensus. So what are the next steps? Well, this work is absolutely live at the moment. A final report on the project has been written. and we are currently putting a paper together on the basis of the findings. And we are submitting it to pediatrics, and the spelling is deliberate there because, of course, pediatrics is a very well-known and influential American scientific journal, and because we had international collaboration, it was felt that pediatrics was probably the best journal to submit the paper to. Paper is almost done and is about to be submitted, so keep your fingers crossed. This paper, hopefully it will be published, will allow us to target researchers, funders and policymakers. We believe that having done this process and identified a consensus on what the research priorities should be will help attract funding from donors and from the big medical research funders. Of course, it's very, very helpful for us. I hope it will be helpful for the other countries, but I believe it will be, because this will form the basis of our research strategy over the next 10 years. And that is currently being prepared, and we will be publishing that in January. And I will be presenting the findings of the project, of the GAPS project, at the International Conference on Stillbirth, SIDS and Baby Survival, which is taking place in Uruguay this month, which is very exciting. So watch this space. We will obviously let you know when the paper is produced. We'll make a lot of noise about it. And last but not least, I just wanted to thank you all very much for taking part in my session. As I said, we're extremely grateful to all of you. Health visitors just make a huge difference to us. And just to remind you, this is the support that we can offer. We have free phone helpline number for anybody who is affected by bereavement, a family member, or indeed if you are, as a professional, affected by bereavement or supporting a family who's been bereaved. Just contact us either through the helpline or just email us on that email address. And if there is any information that you would like, particularly in relation to safer sleep advice, the evidence base, products that you've come across that you're not sure about, ring us on our information line, or again, just email us on info@lullabytrust.org.uk. So that's it from me. Thank you very much, and look forward to working with you and reducing SIDS still further in the coming years. Thank you.